Well, thank you very much indeed, Ara, and thank you very, very much, Klaus, and all of your colleagues for what I always think is the most fantastic meeting every couple of years, so thank you again. This is the last talk of the afternoon. It's going to be fairly brief because I'm going to tell you about something pretty crazy, I think. It's an idea that I had a few years ago, and Klaus has asked me to tell you how we're getting on. So I come from Warwick, which is right in the centre of England. At the top there, you can see a picture of the medieval castle for which Warwick is very famous. But below, I think, is a 2007 castle. That was a new hospital that was built just before the financial crisis. And it's a very nice place to work, but I think we are somewhat responsible for the financial crisis in Europe. So I'm going to talk about antetorsion. Now, for the purposes of this talk, what I mean by that is the twist of the femur between the knee and the hip. And there is a bit of a variation in how people describe that. In my own practice, I use torsion to talk about the femur and version to talk about the acetabulum. So for this talk, that's what I'm doing. Torsion means femur. Now, we reckon that that is roughly 15 degrees, but we recognize that it's a big variation, and it's hard to pin down exactly what is normal. So it's quite a wide range. I think that there are also some controversies about how to measure it. Most of the patients, and certainly all the ones that I treat where I do shape-changing surgery, I presently do CT scans. And so I use a CT scan to measure torsion, comparing the posterior aspect of the femoral condyles with the femoral neck. Now, what do I mean by impaction impingement? Well, if you can make sense of this little diagram, there's a foot at the end of the leg and then a hip joint. If we rotate the hip into internal rotation, then as long as we've got a reasonable amount of femoral antetorsion and no other problems, then the hip will be able to rotate normally and the foot will go into internal rotation, either with the hip extended or flexed. But if we have a patient that starts off with femoral antetorsion when their foot is pointing forwards, so you can see that the femoral head is already somewhat internally rotated in the acetabulum, then there's not as much room for the femoral neck to rotate towards the anterior aspect of the hip, and it will eventually impinge on the labrum. And so that's not really pincer impingement because there's not what we think of as a pincer, but it has the same effect as pincer impingement, that we crush the labrum. Now, this is especially a problem in people who like to do sports in which they do a lot of internal rotation. And I've put ice hockey there. I've only ever treated one ice hockey player in England, which makes me feel a bit strange coming to Switzerland, where that seems to be what you guys do all the time. And Brian, of course, you in the States, ice hockey is a big deal. But for us, we have other sports. So things like hurdling, treat a lot of people who play soccer, a lot of people who do sports when they're in closed up positions. Being a jockey is a good example. Now, we could manage this problem of an abnormal rotation of the femur by doing a rotational osteotomy of the femur. And I think that's what many of us do. It's certainly what I used to do. And there are different ways of doing that. You can see on the left there an osteotomy that's been fixed with a plate. And on the right, these are some slides I got from Oma Maidan in the States, an intramedullary saw, and then an inflatable nail inserted percutaneously. So lots of different ways we could do that. But really all of these feel to me like a bit rather aggressive. We're cutting through the femur, and then we're trying to fix it back together again in a different position. And undoubtedly they do involve a substantial length of time non-weight bearing or limited weight bearing, and there are some risks and complications that can occur. So imagine this idea. Here's a schematic of a hip joint, the femoral head and the femoral neck. So very straightforward there. An alpha angle, and I've measured it here at the 3 o'clock position. Let's say this is a completely normal hip, and we'll notionally give it an alpha angle of 55 degrees. Now, if we were to cut away part of the anterior neck in order to increase the head-neck junction, then we'd be able to increase the clearance at the front of the hip and perhaps abolish that impaction impingement that was going to occur. And in fact, a bit of geometry enables us to work out how much we'd have to remove. So if we removed about 25% of the width of a neck in a hip that has a 55-degree alpha angle, then we'll increase the subtended angle of the head by 15 degrees. Another way of looking at that is that the resection depth on the head-neck junction, as we increase the offset, can be calculated with the sine of the angle we want to achieve multiplied by the radius of the head. And to get a 15-degree increase in coverage of the head, we typically need to remove about 8 millimeters in an average size man. And if we did that, we'd end up making this sort of resection. So we start off with a sort of pretty normal head-neck offset, head-neck junction with a 55-degree alpha angle, and then we remove a big chunk of it. And you might be a bit worried about that, and the only thing that we've got to go on as to whether that's safe is one paper from the Mayo Clinic, Rodrigo Mardones and colleagues there, who said that you could remove about a third of the width of the femoral neck before you needed a much lower energy to break it. That was a cadaveric experiment, not at all clear how relevant that is to real life. So I thought, okay, 25% is about as far as I'm prepared to go, and that will give me 15 degrees of increased spherical coverage on the femoral head. And that's the sort of profile I'm going to end up with, so it's going to look pretty strange. So in 2011, when I decided to start doing this, we set up a protocol to identify patients for a prospective study. And since then, we've collected 12 patients, of whom 10 are male. They're reasonably young. They're all complaining, or were complaining, of groin pain. And actually, they had pretty severe groin pain with an IHOT down around 60. Internal rotation in flexion, we measured as 6 degrees. This is in a sitting position using the sort of rig that Michael Lunig and colleagues here in Bern used some years ago to measure internal rotation in a systematic way. They all had a normal alpha angle, so they couldn't be included in this study if they had an alpha angle over 55 degrees, and they couldn't be included if they had a lateral center edge angle greater than 40. And they all had reduced femoral antetorsion. The mean was 4 degrees, and the range there from -3, so just retroverted, to +7. So you can see we sort of set up these really quite narrow criteria, and then over the course of about 18 months, nearly 2 years, collected these 12 patients. 3 of them were professional athletes, all soccer players. 9 of them were not. They were ordinary people, but they were all quite sporty. They liked playing sport, and sport was a major contributor to their symptoms. They all had MRI scans that didn't show any major disruption of their hip. Articular cartilage good. Labrum often looked a little bit battered and bruised. They all had a local anesthetic injection test to confirm that the pain was indeed arising from their hip joint and not somewhere else. And all of them had to do provocative tests before and after the injection to confirm that it was indeed their symptoms that they got with activity that we abolished with the injection. And the other advantage of the local anesthetic injection test, which I did myself, was that I could have a look at the profile and see impingement occurring. So here's a case, and you can see on the anterior neck there's a bit of irregularity, but there's a normal head-neck offset, a normal alpha angle. Looks like some periosteal reaction, perhaps, further down the neck. And as I flex and internally rotate this patient's hip, look at the impingement, the impaction, that is then subluxing the hip. So you could judge that this patient has an unstable hip as a result of their impingement. And in all these patients, we treated them with arthroscopic surgery. They were guided by CT reconstructions. And the first thing we did during arthroscopic surgery was to try and replicate that position in which we could see the profile. And we were going to keep resecting bone until we matched our preoperative plan, which was between 8 and 10 millimeters of bone resection. And we had 20 degrees of internal rotation in 90 degrees of flexion. And that means removing bone not just from the head-neck junction, but all the way down the anterior and anteroinferior aspect of the neck, so potentially further than one would do during a normal cam resection. In order to do that, you can see I'm orientated here with the femoral head on the left, looking down across the front of the hip. So I actually work the other way around to many people. I'm looking from proximal to distal. And pushing up on the left-hand side there, pushing the zona orbicularis up with a probe and working out laterally under the zona orbicularis. And to get right out there, I often had to divide the zona orbicularis. And that meant that I had to do a capsular repair at the end. Not trying to get a sort of apple bite cut here, but instead to recreate a spherical head. And that means that there must be a concavity on the femoral neck and then a convexity more proximal at the head-neck junction. And that's the sort of resection that we got. You can see the head is nice and spherical. If I mark out where the profile was before, you can see the bone that's been removed, and in this case that was about 9 millimeters at maximum depth. But you can see it goes right out to the point where the capsule inserts into the intertrochanteric line, and sometimes I'd even lift up the capsule and go further lateral. Post-op, we were pretty sure that movement was going to be important because we were worried about adhesions of the capsule back onto that big, wide resection. We got all the patients onto CPM in the operating room. We got them all working with a physiotherapist doing early range of movement exercises. We tried to do things like working in the pool, getting them up on their feet on an exercise machine, but we were cautious about weight bearing. We didn't make them non or partially weight bearing. They could fully weight bear, but we asked them not to do any impact. So this girl is running on a reduced gravity running machine there. Now, results. Well, we had one patient, it was actually our first one, who didn't seem to do very well at first. Had pain, had a sensation that something was catching in their hip. We concluded that they probably had an adhesion. We gave them a steroid injection and we went to town on the rehab with lots of range of movement exercises, and they got better and have not had any problems since. So ever since then we've been much more aggressive about range of movement exercises immediately after surgery. We've had no fractures and no patients who've expressed a sense of instability. We were worried about that because we worried that the labral seal might not be retained as it went all the way around the front, but that hasn't been a problem. All the patients have got an improved range of movement. Remember, there was 6 degrees of internal rotation before surgery. Mean is 19 afterwards. And we have some pretty good clinical results. Here's the IHOT coming up from down in the 50s up to almost normal. And this pattern's pretty similar to typical young male FAI patients. And that's been retained now for 24 months. So our shortest follow-up on these patients is 24 months now. We had hoped we could get them back a bit faster than if we did osteotomies, and I think the truth is we probably haven't. So this is those 12 patients, and they were all doing some sort of training by 12 weeks, and 3/4 of them were back to competition by 18 weeks. But that didn't include 2 of the professional athletes, and you see that some of them have taken 6 months to get back to sport. So it's not at all clear that doing it this way is very, very fast, although it may be a little faster than doing a femoral osteotomy. So to conclude, this is a suggestion for you, an idea to take away, that it may be that we can treat impaction impingement caused by low antetorsion by hip arthroscopy and reshaping. It definitely improves the range of movement and it relieves symptoms. It is safe to do it, at least to the degree that I have been doing it. So I've been making the correction that's necessary for someone who has retrotorsion that's just getting into the negative numbers, maybe as much as -5 degrees. Beyond that, I have no idea whether it would be safe, and I'm doubtful that it would. But in that range, I think this is a suitable alternative to femoral osteotomy. Thank you.